Welcome to Week 9. We've discussed bias and confounding, the alternative explanations for observed associations. Today we tackle the big question: when can we conclude that an association is causal? This is where epidemiology gets philosophically interesting. Proving causation with absolute certainty is impossible. We can always imagine an unmeasured confounder or unknown bias. Yet we make causal judgments constantly in medicine and public health. The frameworks we'll discuss today help us reason systematically about causation, weighing evidence across multiple dimensions rather than relying on any single study. Let's start with why causal inference is difficult. Association does not equal causation. You've heard this since introductory statistics. Ice cream sales correlate with drowning deaths, but ice cream doesn't cause drowning. Both increase in summer. Correlation is easy to observe. Causation requires eliminating alternative explanations, bias, confounding, chance. And we can never eliminate them with certainty. Here's the fundamental problem: we can never observe the counterfactual. For any individual who took a drug and recovered, we can't know what would have happened if they hadn't taken it. We can compare groups, but groups differ in ways beyond the exposure. No single study proves causation. Multiple studies with different designs, populations, and potential biases are needed to build a convincing causal case. Ultimately, causal inference requires judgment. Statistical tests can't tell you whether an association is causal. Humans must weigh evidence against criteria and reach a conclusion. Sir Austin Bradford Hill proposed criteria for evaluating causal associations in 1965. These remain the most influential framework for causal inference in epidemiology. Strength of association: strong associations are less likely to be entirely due to bias or confounding. A relative risk of 10 is more convincing than 1.2. But weak associations can still be causal. Consistency: has the association been observed by different investigators, in different populations, using different methods? Consistent findings across diverse studies strengthen the causal case. Specificity: does the exposure cause this particular disease rather than many diseases? Specificity supports causation but isn't required. Smoking causes multiple diseases yet is clearly causal. Temporality: does exposure precede disease? This is the only criterion that's absolutely required. Cause must come before effect. Biological gradient: is there a dose-response relationship? More exposure, more disease. This supports causation but may not exist for threshold effects. Continuing with Bradford Hill's criteria. Plausibility: is there a biological mechanism that could explain the association? This depends on current knowledge. Lack of known mechanism doesn't disprove causation, as mechanisms are often discovered after associations. Coherence: does the causal interpretation fit with what we know about the natural history and biology of the disease? Evidence shouldn't conflict with established knowledge. Experiment: does removing the exposure reduce disease? Does adding it increase disease? Experimental evidence, from RCTs or natural experiments, strongly supports causation. Analogy: do similar exposures cause similar diseases? If one medication causes liver damage, finding that a related medication causes liver damage is more plausible. Important: Bradford Hill himself emphasized these are viewpoints to consider, not a checklist. None except temporality is necessary or sufficient for causation. Strong associations can be confounded, weak associations can be causal. The criteria guide judgment, not replace it. Let's apply Bradford Hill to the classic case: smoking and lung cancer. Strength: heavy smokers have 10 to 30 times the lung cancer risk of never smokers. This is a very strong association, hard to explain entirely by bias or confounding. Consistency. The association has been found in case control studies, cohort studies, in men and women, across countries, over decades. Remarkably consistent. Temporality. Smoking begins years to decades before lung cancer develops. The time sequence is correct. Gradient. Clear dose response, more cigarettes per day, longer duration, higher risk. Quitting reduces risk over time. Coherence. When smoking rates began declining in men in the 1960s, lung cancer rates followed about 20 years later. The population-level data fits the causal model. Plausibility. We now know carcinogens in tobacco smoke cause DNA mutations. This mechanism wasn't fully understood when causation was first concluded, demonstrating that plausibility follows rather than precedes causal judgment. The totality of evidence convinced even skeptics. By the 1964 Surgeon General's report, causation was established. Modern epidemiology increasingly uses causal diagrams, specifically directed acyclic graphs or DAGs. A DAG represents causal relationships visually. Arrows point from causes to effects. No loops are allowed, hence acyclic. DAGs help identify confounders, variables that are common causes of exposure and outcome, creating backdoor paths between them. They also identify colliders, variables that are effects of both exposure and outcome. Controlling for colliders can introduce bias rather than remove it, a counterintuitive finding that DAGs clarify. DAGs guide analytical strategy. They tell you which variables to adjust for and which to leave alone. Adjusting for the wrong variables can increase bias. You'll see DAGs increasingly in epidemiologic research. They make causal assumptions explicit and allow formal reasoning about confounding structure. For healthcare managers, you don't need to construct DAGs, but understanding that causal structure determines appropriate analysis helps you evaluate studies claiming to control for confounding. How does causal inference apply to healthcare management? Everywhere. Program evaluation is fundamentally about causal inference. You implement a program and outcomes improve. Did the program cause the improvement? Or would improvement have happened anyway? Regression to the mean is a common trap. If you intervene when things are bad, they often improve regardless. Concluding the intervention worked requires ruling out this alternative explanation. Quality improvement is applied epidemiology. Before and after comparisons without controls can't establish causation. Secular trends, seasonal variation, and other factors may explain changes. Always ask, what else changed? Could something other than our intervention explain the improvement? Healthy skepticism serves you better than premature conclusions. Natural experiments, policy changes, system disruptions, provide opportunities for causal inference when randomization isn't feasible. Comparing outcomes before and after policy changes, or between affected and unaffected groups, can strengthen causal conclusions. Quasi-experimental designs like interrupted time series and difference indifferences improve on simple before-after comparisons by explicitly modeling counterfactual trends. Let's summarize causal inference. Association doesn't equal causation, but sometimes associations are causal. The challenge is distinguishing causal from non-causal associations. Bradford-Hill criteria provide a framework for this judgment. Strength, consistency, specificity, temporality, gradient, plausibility, coherence, experiment, and analogy, consider each when evaluating evidence. Temporality is the only necessary criterion, cause must precede effect. The others strengthen the causal case but none is required and none is sufficient alone. DAGs formalize causal reasoning and guide analytical strategies. They're increasingly common in epidemiologic research and make assumptions explicit. As healthcare managers, you make causal inferences constantly. Did this intervention work? Did this policy improve outcomes? Applying causal thinking helps you reach better justified conclusions and avoid being fooled by spurious associations. Next week, we turn to applied epidemiology, screening programs and surveillance systems. Assignment: find a claim that an intervention caused an improvement, in the literature or your organization. Apply Bradford Hill criteria. How strong is the causal case? See you next week.